മുഹമ്മദ് അലിയാണോ? കോളറൊക്കെ മതിയാണോ? മ്യൂട്ട് മാറിയോ? ഇല്ലല്ലോ, ഞാൻ ലൈനിലുണ്ടോ? ഇല്ലല്ലോ. Hello.
Hello, sir.
Hello. Good afternoon. I am Dr. Sam.
Yes, sir.
Good afternoon, sir.
Good afternoon.
Sir, we can start at 3:01, sir. We'll give 1 minute for the participants to register their do the registration, and we can start at 3:01, sir.
Yeah. Camera cut ചെയ്യാം, വീഡിയോ ചെയ്യാൻ വേണ്ടി. പടമെടുക്കാം. ഞങ്ങൾ നിന്ന് പടമെടുക്കാം.
Hello.
Good afternoon, sir.
Hello, Doctor. Good afternoon, Dr. Sam.
Good afternoon.
I'm Balaji from Shield. Thank you very much.
Yeah.
Thanks a lot, sir. I'm traveling. I'm in Vizag. So my doctor will. Yeah.
Okay. Thank you.
Thanks a lot. I will talk to you after the program is over, doctor. Thank you.
Thank you,
doctor. Thank you.
Thank you.
So, good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today is recent advances in management of poor responders. And I request the participants to post their queries in the comment box so that we can have a discussion at the end of the session. And now it's time to introduce our event speaker for the day, Dr. Sam P. Abraham. So, sir is currently the medical director for Abraham. One second. So, sir is the medical director for Abraham's Infertility Research and Test Tube Baby Center, Changanateri, Kerala. And sir is experienced in doing advanced laparoscopy, IVF, ICSI, and sexology procedures. Sir has presented papers on infertility gynecology and sexology in state, national, and international conferences. Sir has participated as a faculty in endoscopic and ultrasound workshops. Sir has won the Millennium Excellence Award for Excellency in 2001, and Sir has also won Atura Seva Award for Patient Care in 2014. Doctor has been awarded Gandhi Puraskaram Award for Excellency in the field of infertility from Mahatma Gandhi Peace Foundation. So, with this introduction, I welcome you, sir, and you can take over the session, sir.
Thank you very much. I'm grateful to Shield Healthcare for giving me a chance to talk on this topic on poor responders. So this poor responders is something of great interest for clinicians because it's a great challenge to all of us because they have come to you with great expectations after so many failed attempts. So let us see what exactly it is. So we'll be starting from the basic things and we'll go to the advanced and later developments in the field. Just to give you a concept about the physiology of the procedure. Now, poor responders represent a significant proportion among women undergoing ovarian stimulation. So it is to the range of about 9 to 24%. So you can see the number is quite high. 9 to 24% of persons undergoing ovarian stimulations, in them poor responders is a significant proportion. So practically everybody in this field is facing this problem. Despite the advancement in assisted reproduction technologies, the poor ovarian reserve response is still considered to be one of the challenging tasks in reproductive medicine because we don't know whether we'll get the embryo, and the patient has also, because as we know the patient is spending a lot of money and they have got a great belief in you, that's why they are coming. So notably, poor responders are not a homogeneous population and their prognosis vary. So it is not only on the age, but it is something based on the number of oocytes retrieved. So poor responder, there is a discrepancy in the definitions. That is the biggest problem. So it makes the comparison of studies difficult. In 2011, a systematic review by DeVroy reported a shocking number of 41 different definitions of poor ovarian response in 47 randomized trials that act as an alarm bell for the medical community. You can see that there is a different definition that shows there was no uniform idea about it. So in the same year, Eshrey attempted to reduce the vast heterogeneity underlying the definition of poor ovarian response by introducing the Bologna criteria. So this was first in the series of that. So Eshrey campus workshop was organized in Bologna, involving all the Eshrey special interest groups and the majority of research groups who have significantly contributed to the field. The main objective of the workshop was to reach on the definition and diagnosis of poor ovarian reserve. Who is a patient with a poor ovarian reserve? So the first systematic effort to define women with poor ovarian response stimulation is in the Bologna criteria of Eshrey 2011. So what their consensus was that at least two of the following three features must be present. One is an advanced maternal age of more than 40 or any other risk factor should be there. First thing, if the lady is more than 40 years, just because of that or any other risk factor. And the second was that the poor ovarian response, that is, her cycles were cancelled or she got less than 3 oocytes in a conventional protocol. And the third was she had an abnormal ovarian reserve test where the antral follicle count is 5 to 7 follicles or anti-Mullerian hormone 0.5 to 1.1 nanogram per ml. So three criteria. First is advanced maternal age, other risk factor. Second was a poor ovarian response, cycles cancelled or less than 3 oocytes with a conventional protocol. Third was an abnormal ovarian reserve test, antral follicle count 5 to 7 follicles or anti-Mullerian. These were the three criteria. Or there was one more clause. 2 episodes of poor ovarian response after maximum stimulation are sufficient to define a patient as a poor responder in the absence of maternal age or abnormal ovarian reserve. that means the patient is not at advanced maternal age. We know the first criteria was advanced maternal age. But there were cases we all face in our clinical practice that there is no advanced maternal age, there is no abnormal ovarian reserve test, but the patient, you get the poor oocyte retrieval. So that was the fourth clause. And these were the three, and or 2 episodes of poor ovarian reserve after maximum stimulation are sufficient to define patient as a poor responder in the absence of maternal age or abnormal ovarian reserve test. So by definition, poor ovarian reserve, when we call poor ovarian response, it is because of the ovarian response is poor. So once it is considered essential for diagnosis of ovarian response. However, patients over 4 years of age with abnormal ovarian reserve test may be classified as poor responders. Here, here the problem is that's not they need not have one stimulated cycle. Only thing is that they are over 40 years with an abnormal ovarian reserve test. Since both advanced age and abnormal ovarian reserve test may indicate reduced ovarian reserve and act as a surrogate of ovarian stimulation cycle. So in this patient, the patient should be more properly defined as accepted poor ovarian response. So this is the consensus that was reached. Now this is the Bologna criteria. You can look at the age of the patient, 30 years. Now you can see the cancellation and one where you get less than 4 oocytes. So 2 boxes are there. One is the cancellation rate and second is the oocytes. You can see that as the age is advancing, what do you see? The cancellation rate and number of oocytes retrieved is more. So as the age is advancing, so the relationship between the age, cycles cancel because of absent or low ovarian response or pickup with less than 5 oocytes. So in the first cycle in Bologna and in the Modena IVF University unit has been between January 2004 to December 2009 is shown here. So all the patients here underwent conventional ovarian stimulation protocol with different FSH and HMG starting dose. As expected, the prevalence of poor ovarian response increases with female age. So you can see 2 boxes here. You can see as the age advances, the cancellation rate and less than 4 oocyte number is more. So the Bologna criteria, critical evaluation of the criteria are used. So other than age, large number of clinical parameters might predict the poor ovarian response to stimulation with gonadotropins and are introduced in the clinical practice. Other than the age, what are the other parameters look? One, we all know, one is age. We clearly told 40 years. Others are, as we know, it is a basal FSH, inhibin B, antral follicle count, ovarian volume, a number of dynamic tests, and anti-Mullerian hormone. So basal FSH, inhibin B, AFC, ovarian volume, anti-Mullerian hormone, all these tests help you to predict a poor response to stimulation. For all the tests, antral follicle count, anti-Mullerian hormone has the best sensitivity and specificity for producing the ovarian response. However, even with the best ovarian reserve marker at the best cutoff value is associated with a false positive rate. That is the problem. So even with the best ovarian reserve, you have a false positive rate of about 10 to 20%. Now, Brookmans concluded that ovarian reserve tests had modest clinical utility because of their limited predictive properties and hypothesized that ovarian response during the first IVF cycle could be used as a surrogate ovarian response test. So what is that ovarian reserve test at best clinical utility? Because of their they have got a limited predictive property. We already told this FSH, inhibin B, antral follicle count, ovarian volume, ovarian dynamic test, anti-Mullerian hormone. What is their problem? They have limited predictive property. So what is the important thing? It is the ovarian response during the first IVF cycle that could be used as a surrogate ovarian response test. So anti-Mullerian hormone and antral follicle count must be considered as the most reliable and accurate marker of ovarian response. So their overall performance in the prediction of poor response is acceptable, although not optimal. So anti-Mullerian hormone and antral follicle count as the most reliable and accurate marker of ovarian reserve. This is the Brewer et al. Study 2009. So their overall performance in the prediction of poor response is acceptable. I am clear now. I am audible now. I am audible now.
Yes,
Hello?
sir, you're audible.
Okay. Now here, what you can see is a decline in oocyte and follicle pool in the reproductive events. Now you look at the age of the patient. Now at birth, you can see it is around about 10 lakhs. Now optimal fertility, it comes down. So there is a decline in fertility. You can see by 41, what happens? There is an end of fertility. By 31 to 40, there is a decrease in fertility. So what is the optimal fertility age? It is somewhere between 18 to 31. So by the time the lady goes for 45, she has got irregular cycles. You can see on the left side, her follicle number comes to between 10,000 to 1,000. So at birth, it is about 10 lakhs. Then you can see optimal fertility, it comes down. Decrease in fertility is there. Then end of fertility is there. Then irregular cycle is there. And by 51, she goes for menopause. This is the declining oocyte follicle pool in the reproductive event. A comparison of widely used markers of ovarian reserve. Whom do you characteristic as a good marker? One is the age, then anti-Mullerian hormone, FSH, and antral follicle count. Here you can see prediction of poor response, anti-Mullerian hormone and antral follicle count are having 3+, while age is having 1 and FSH is having 2+. Now prediction of hyper response. Here also again, anti-Mullerian hormone and antral follicle count 3+. You can see age is only 1 and FSH is 1 only. So lower intercycle variability is high for age and AMH, but FSH is having a variability, AFC is also having a variability. So lower intracycle variability is there for age only, AMH, and then antral follicle count is there. Applicable to all patients is age and AMH, and economic is age is the most single factor. So you can see 1 negative is not appropriate, +1 is not very appropriate. You can see that prediction of hyper response, FSH is not very appropriate. For prediction of hyper response, AFC is very appropriate. You are getting 3+. And then prediction of poor response, you can see age is not that appropriate. Anti-Mullerian hormone, very appropriate, and antral follicle count, very appropriate. So what is the etiopathogenesis? Why some people are having a poor ovarian response? That's what we are all worried. Some of the recognized etiologies, one is age-related depletion of the ovarian follicle. Second one, the patient is having advanced endometriosis, or she may be having a chromosome or a genetic alteration. If she has had a prior ovarian surgery and pelvic adhesions, it could be a cause. Metabolic and enzymatic diseases could be a cause. Toxic, autoimmune, infectious diseases, all these problems can cause. Patients ask you, why, doctor, what happened? Suppose the patient is having advanced endometriosis. It could be that she is having a chromosomal or a genetic alteration. So in a lady with a poor ovarian previous surgery, or she had pelvic adhesions, and where she had metabolic and enzymatic diseases, toxic, autoimmune, infectious diseases, all these things can lead to a poor ovarian response. So what is the etiology of poor ovarian response? There is a depletion of ovarian follicle pool, insufficient initial follicle number. So there is it could be that she has got an insufficient initial follicle number, or it could be that she has got an accelerated follicle loss, or it may be that she has got an iatrogenic one. Ovarian follicle dysfunction is there. Signalizing defect could be there, enzyme deficiency could be there, autoimmunity could be there, idiopathy could be there. Then risk factors, advanced maternal age, lifestyle-related factors, smoking, obesity, endometriosis, chemotherapy, radiotherapy, previous pelvic adhesions, genetic, all these things are etiologies for poor ovarian reserve. So lifestyle-related factors, endometriosis, chemotherapy, radiotherapy, previous pelvic adhesions, genetic, all could be a cause for, they are all risk factors. So what are the risk factors? Risk factor is advanced female age, lifestyle-related factors, smoking, obesity. She is having endometriosis. She is having ovarian surgery. She had chemotherapy, radiotherapy, previous pelvic adhesions, genetic. All these things could be a cause. So, prediction of live birth rate according to the number of retrieved oocyte. You can see that age 18 to 34, 35 to 37, 38 to 39, 40 and over. You can see that cumulative live birth rate per started cycle should be considered today as the most important. When do you say that IVF is successful? It is based on the cumulative birth rate. You can see from the graph that as the age is advancing, cumulative live birth rate come down. So you can see the graph on the 18 to 34. It goes to 40. Then you can see 35 to 37 years. Then you can see that 40 and over. You will be able to see it comes down as low as 17.5%. So is a higher ovarian response after stimulation for IVF is related to a high number of euploid embryos? Yes. So aneuploidy rate didn't increase with the ovarian response or gonadotropin dose. So 46 oocyte donors, ovarian stimulation with 150 international unit of recombinant FSH and 75 international unit of HMG in a GnRH agonist protocol. When the ovarian response was above the median, that means more than 17 oocyte, the mean number of euploid embryos per donor was about 5, while when the oocytes were less than 17, you can see the number of euploid embryos was 2.7. So aneuploidy rate didn't increase with ovarian response or gonadotropin dose. What are the trends in poor ovarian responder research? Lessons from RCT. A variety of criteria has been used to characterize poor responders. One is heterogeneity of the poor ovarian response criteria. Women with previous low ovarian response to IVF, women expected to exhibit low ovarian response to planned IVF ovulation induction, either proven or expected poor responders. Women fulfilling the recently published Bologna criteria, other deficient. You can see the frequency of various poor responder definitions appearing in randomized trials. Other Bologna criteria, you can see expected poor responder. You look at the graph. So expect the graph that is there 5-year past, then proven expected poor ovarian responder, poor ovarian responder based on previous performance. So you can see that the Bologna criteria, then you will be able to see the expected poor responder and proven or expected. These are the 5-year period study frequency of various poor responder. So Bologna criteria for poor responder, there are certain limitations. What are the limitations? Because it was not 100% successful in its intended primary goal. So among the interventional trials registered, clinical trials, the number of subjects enrolled in such trial varied markedly from 23 to 939, but the vast majority of the trials were not powered to detect the difference in pregnancy rate. So Bologna criteria limitation was that the correct identification of the subset of women with poor prognosis in IVF, apart from its usefulness in terms of clinical management and counseling, would be necessary from a public health perspective. That is, the correct, what should be the criteria? It should be correctly able to identify the subset of patients with poor prognosis in IVF. You are not that much bothered about the clinical management and counseling. You should be able to identify that subset of women with poor prognosis in IVF patients. Then only this criteria has got a value. So that is why the Bologna criteria limitations, that although the SRA consensus established the minimum criteria of definition of poor ovarian response, numerous patient categories with potentially different prognosis might be generated during the Bologna criteria. Criteria less than 40 years, more than 40 years. So it could be combined with different patient categories generated by combining the parameters used to define the poor ovarian response, combined with one previous poor ovarian reserve episode, abnormal ovarian reserve test, other risk factor, one previous poor ovarian response episode, abnormal ovarian reserve test, one previous poor ovarian response, age more than 40 years, other risk factor, abnormal ovarian response test, abnormal ovarian response test where the age is more than 40 years. It could be that they have got other risk factors. Previous poor ovarian response episode could be there. 2 previous episodes of poor ovarian response could be alone, or it could be with any other criteria. So Bologna criteria limitation entail the risk of grouping together women who differ significantly in their biological characteristics. For example, Young women with low ovarian reserve associated with previous episode of poor ovarian response. She is a young woman, but she has got a low ovarian reserve. But there could be young women with normal ovarian reserve where they have two poor ovarian response episodes. So older women, more than 40 years with normal ovarian reserve and with a poor ovarian response previous episode. So they are all assigned in the same category, even though we know that the clinical management is different. So in a young patient with a low ovarian reserve associated with a previous episode of poor ovarian response, young women with a normal ovarian reserve, older women more than 40 years with a normal ovarian response, they are all included in the same category. But we know that the clinical management needs different pattern. What is the problem? It don't take into account the ovarian resistance to exogenous gonadotropin. This is something we all have faced because when we give gonadotrophins, the resistance to gonadotropins we feel. So Bologna criteria limitation is that despite the overall notion that the prognosis of a patient undergoing IVF can be measured by the number of oocytes retrieved, the valid critical Bologna criteria is that these standards fail to identify young women with expected poor ovarian response due to abnormal ovarian biomarkers. That is, women below 35 years who have not undergone ovarian stimulation. So what is the Bologna criteria limitation? They identify to fail. They fail to identify young women with expected poor ovarian response due to abnormal ovarian markers. That is, women below 35 years who has not undergone ovarian stimulation. So she need to have an ovarian stimulation to identify the poor ovarian response. That was the limitation of Bologna criteria. So it has been criticized for several reasons. Why? Lack of clarity in defining the risk factors, lack of accounting the oocyte quality. The major issue that the persistence of a significant degree of heterogeneity even within the Bologna criteria population. Several patterns or subgroups could emerge by combining risk factors, ovarian reserve test, and IVF attempt. So Bologna criteria has been criticized. So subsequent, these subpopulations of patients often vary present with different baseline characteristics. So subsequent investigations confirmed a poor prognosis of Bologna criteria, poor ovarian reserve, low birth rate to 2.3 to 8.7% per started IVF cycle. It revealed a lack of homogeneity between the subgroups. A 15-year follow-up of 3,390 women with poor ovarian response revealed that cumulative live birth rate decreased from 22% for women less than 30 years to 18.3% to women aged 31 to 35 years. So cumulative live birth rate decreased from 22% for women less than 30 years to 18.3% to women aged 31 to 34 years, 17.2 to 35 to 37 years, 13.5 to 30 to 40 years, and 10.5% for 41 to 43 years, and 4.4% among women with 43 years. So this was a 15-year follow-up of poor ovarian response revealed that cumulative live birth rate decreased radically with the age, 17.2% for 35 to 37 years, and 4.4% women aged less than 43 years. So the heterogeneity in Bologna criteria could explain none of the treatment modalities has been shown to be effective. Reluctance of the fertility experts to use Bologna criteria in the poor ovarian response study. So here comes the post-ground criteria. So as I told that Bologna criteria had its own limitations. So this new classification introduces a better satisfaction of the low prognosis patients and suggests it is more specific. So suboptimal response. What is the suboptimal response? Where you get retrieval of 4 to 9 oocytes at given age with a significantly lower live birth rate compared to normal responder. Where you are getting 4 to 9 oocytes at any age. It's not related to age. Hyper response, where you need high dose of gonadotropins and more prolonged stimulations are required to obtain adequate number. So one is suboptimal response, where you don't get an optimal response. Hyper response is different, where you need high dose of gonadotropins and more prolonged stimulations were needed. So propose new satisfaction. So you have to combine the qualitative and quantitative parameters, age of the patient, expected employed rate, and biomarkers and functional. As I already told, two important factors, anti-Mullerian hormone and antral follicle count. I am audible now. Hello. Hello.
Sir, you're audible, sir. You can continue,
Yeah.
sir.
Yeah. Post-note group, patient-oriented strategies encompassing individualized oocyte number. There are 4 groups. Group 1. What is the group 1? It is a young patient. She is less than 35 years with adequate ovarian reserve parameters, where her antral follicle count is more than 5. Anti-Mullerian hormone more than 1.2 nanogram per ml with an unexpected poor or suboptimal ovarian response. Subgroup 1A, less than 4 oocytes. Subgroup 1B, 4 to 9 oocytes treated after standard ovarian stimulation who at any age have a lower live birth rate than age-matched normal responder. So group 1 is a patient, young patient. What is her age? It is less than 35. Her adequate ovarian reserve parameters are there. Her antral follicle count is good. Anti-Mullerian hormone level is more than 1.2 nanogram. Then what happened? You are having an unexpected poor or suboptimal ovarian response. 1A, where you get less than 4 oocytes. Subgroup 1B, where you get 4 to 9 oocytes retrieved, where you followed a standardized ovarian stimulation protocol. They have got a lower live birth rate than age-matched normal responders. What is group 2? It is an older patient, where the age of the patient is more than 35. She has got an adequate ovarian reserve parameters. What was the antral follicle count was more than 5. Her anti-Mullerian hormone, 1.2 nanogram per ml. There also you had an unexpected poor or suboptimal ovarian response. Subgroup 2A, less than 4 oocytes. Subgroup 2B, 4 to 9 oocytes after standard ovarian stimulation, who at any age would have a lower live birth rate than age-matched normal responder. This is the group 2. What is the group 3? Group 3, it is a patient with less than 35 years with a poor ovarian reserve pre-stimulation parameters. That is AFC less than 5 and anti-Mullerian hormone less than 1.2 nanogram per ml. Group 4 is a patient 35 years with a poor ovarian reserve pre-stimulation parameters. AFC is less than 5, anti-Mullerian hormone less than 1. So there are 4 groups. Group 1, age of the patient less than 35. Group 2, age of the patient more than 35. Group 3 is a patient less than 35 with a poor ovarian reserve. Group 4 is a patient 35 years with a poor ovarian reserve pre-stimulation parameters. So this is the thing. So what is the advantage? It is you are able to personalize the treatment protocol. What is that? Different GnRH analog regimes could be there. You are able to depict polymorphism of gonadotrophins at their receptors. Why you get a hyper response? Why you get a hyper response? You get a suboptimal response. It could be that they could have a polymorphism of the gonadotrophins and their receptors. So you have to tailor the FSH starting dose, personalizing the gonadotrophin dose, FSH monotherapy or LH containing drug, and evaluating special regimes including oocyte embryo accumulation to maximize the outcomes. So prostrone criteria, the incorporation of age, oocyte yield, and ovarian reserve into the post-dawn classification allows distinction of the 2 main categories. Expected. Group 3 and 4, you are expected. Why? Because you know that the reserve is low. Unexpected. Group 1 and 2, where you know that their basic parameters were good. So it is an unexpected poor ovarian response. Group 3 and 4, you are expected. So this is able to give a clear distinction of the 2 main categories. So post-dawn group 1 to 4 represent half of all patients attending the fertility treatment clinic. So here you are having the expected group, group 3 and 4. You are having the unexpected group, group 1 and 2. Now group 1 and 2 is unexpected. Why you call it so? Because they have got an adequate ovarian reserve parameters. Their FC was more than 5, and the Mullerian hormone was more than 1.2 nanogram per ml. So you thought that you are expecting a good response, but when it came as an unexpected poor ovarian response group. So what are the strength and weakness? There is a lack of clinical validation, arbitrary cutoff for suboptimal response, intraoperative variability for AFC evaluation, variability in AMH level while you are using manual assays. What are the threats? The threat is that risk of reluctance to be used by the clinicians, poor recruitment of patients due to strict criteria, cost effectiveness is an issue. What are the strengths? You are including both the quantitative and qualitative parameters are involved, better stratification of the low prognosis patient and more homogeneous subpopulation for lower prognosis women. Weakness, as I already told, there is a lack of clinical validation because inter-operator variability for antral follicle count evaluation is there and variability in anti-Mullerian hormone using manual assays. What are the opportunities again? Because conduction of studies and evaluation of treatment modalities in the different groups, recommendations on management according to clinical prognosis is there. So ART calculator predicting the minimum number of oocytes to obtain at least one euploid blastocyst is there. So what is the comparison between the Bologna criteria and post-on certification? Bologna criteria, maternal age more than 40 years, a previous poor ovarian response. Post-on group, age less than 35 with adequate ovarian response, but you are getting an unexpected poor ovarian response. Group 2 is one where you get an abnormal ovarian reserve test. And group 3 is group 2, post-on criteria, age more than 35 years, they have got adequate ovarian. Group 3, maternal age less than 40 years, an abnormal ovarian reserve test. For maternal age more than 40 years with an abnormal ovarian reserve test. So age more than 35 years and abnormal ovarian reserve. So these are the comparison between the Bologna criteria and post-on criteria. So unexpected poor ovarian response, why it is so? A remarkable number of women, why you are getting a normal ovarian reserve test. You tell the patient, I am getting a good output for you, expecting a good output from you. So abnormal ovarian response, but after ovarian stimulation, you see that you get an abnormal ovarian response. Although the exact prevalence of hyperresponsiveness to controlled ovarian stimulation is difficult to estimate, it is supposed to range somewhere between 40 and 45%. So it's not a single this thing. About 40 to 45% who are having an hyper response to controlled ovarian stimulation is difficult to estimate. So unexpected poor ovarian reserve, hyper-responders represent a patient category differing from the classical responders and the classical poor ovarian responder. So who is an hyper-responder? Is a patient with a normal ovarian reserve who ends up having an unexpected suboptimal response to ovarian stimulation because they have got a low follicular output rate and use of increased dose of gonadotropin or lower than expected number of oocytes retrieved. What is this fault? What is the fault is the follicle output rate. What it measures the consistency between the pool of antral follicles at the beginning of the ovarian stimulation and the number of pre-ovulatory follicles at the end of stimulation. What is the follicle to oocyte index? It assesses the consistency between the pool of antral follicle at the beginning of ovarian stimulation and the number of oocytes retrieved at the end of oocyte pickup. Thus, a discrepancy between the available antral follicle pool and the number of pre-ovulatory follicle at the end of stimulation, that is where you get the fault. That is, the follicle output rate is less than 50%, or the number of retrieved oocytes, FOI, is less than 50%, is suggestive of hyperresponse. Hope it is again clear to you. This fault is the one, there is a discrepancy in the number of pre-ovulatory follicles at the end of stimulation. That is, the 40 is less than 50. The number of retrieved oocyte, that is the follicle to oocyte index ratio, is very suggestive of hyperresponsive to gonadotropin. So follicle output rate, where you get the number of pre-ovulatory follicles at the end of stimulation. So these are the two criteria. So normal follicle oocyte index, you can see oocyte number and the follicle count. Low follicle oocyte index, less than 50%, you get it. This is the response. So pathogenesis of low follicle to oocyte index, what are the reasons? It could be that you had a low gonadotropin starting dose. It could be that the patient is having a genetic or environmental problem. There could be that an asynchronous follicle development could be there. So there could be a technical issue involving the triggering for final oocyte maturation, and in the oocyte pickup there could be a problem. So unexpected, poor or suboptimal ovarian response, the most dominant theory is shows a polymorphism, single nucleotide polymorphism in the receptor or genes of gonadotropins. Most well-studied Patients homozygous for serine may require more gonadotrophins and have a longer stimulation compared with heterozygous or homozygous for asparagine counterpart. So it may be that they have got an homozygous state for serine, or it may be that they have got a homozygous state for asparagine counterpart. That means they have polymorphism. That means they have single nucleotide polymorphism in the receptor or genes of gonadotrophins. So can we overcome the poor or ovarian response by increasing the dose alone? Yes, when only if it is because you are not reaching the threshold of stimulation, or if it is having a low follicular sensitivity. But if it is due to presence of very fewer androgen follicle count, then it is not. You are not able to overcome it by increasing gonadotrophin. When you should increase the gonadotrophin, only that you are not reaching the threshold of stimulation, or you are having a low follicular sensitivity. This could be there. So you could see that more oocytes were retrieved in higher gonadotrophin dose group. The Cochrane meta-analysis reported no significant difference in live birth rate between 150 international unit and 300 to 450 unit of gonadotrophins. No case of moderate or severe OHSS in either group. So you can see that more oocytes were retrieved in the higher gonadotrophin group. So 300 wise, 450 wise, 600 unit international unit of FSH. Is there any difference in outcome? 300 international unit, you got 5.2 plus or minus 0.4. Mature oocyte was 3.7. 450, you can see you got 6.7. Mature oocytes was 4.9. 600, you can see it is actually less than 450, where you get 6.6 plus or minus 0.7. So you see that up to 450 it is okay. More than 50 it is not viable. So 450 more than 450 international unit total oocytes, mature oocytes, embryo transferred is more for 450. It is better than 300 but lower than 600. So 300 wise, 450 wise, 600 international unit of FSH outcome is always better for 450 group. So Cochrane meta-analysis reported no significant difference in ongoing pregnancy rate or the number of oocytes retrieved between 300, 400 to 450 international unit of dose of gonadotrophin, and no cases of moderate or severe OHSS in either group. The starting dose that seems to be universally accepted is 300 international unit per day. Maximum dose should be 450 international units per day, not more than that. A gonadotrophin more than 30 international units is not recommended for predicted poor ovarian responder. So worldwide study on the poor responders, 45 countries, GnRH agonist long protocol 9%, GnRH agonist short protocol 20%, GnRH agonist antagonist 53%, GnRH agonist using flexible regime 2%, short protocol was 15%. So comparison of GnRH agonist versus GnRH agonist protocol in poor ovarian responders, reduced duration of stimulation with antagonist, and no difference in oocyte or cycle cancellation rate. So long gonadotrophin, now here you can see that meta-analysis that no difference in oocyte, comparison of GnRH antagonist versus agonist protocol, you can see that there is no difference in oocyte. Reduced duration of stimulation with antagonist. So there is no difference in oocyte or cancellation rate between GnRH antagonist and GnRH agonist protocol. But the advantage is that reduced stimulation is needed with antagonist protocol, so that you get you are able to reduce the dose of drugs. So you can see that regarding whether the GnRH antagonist or agonist protocol is better in poor responders, it is that there is no difference in oocytes or cancellation rate. Long gonadotrophin releasing hormone agonist versus short agonist versus antagonist regimes in poor responders undergoing in wildlife fertilization, a randomized study. GnRH agonist long regime group, GnRH agonist with a short regime group, GnRH antagonist regime group, overall value. You can see that duration of stimulation was 12.4 in the GnRH agonist long regime. GnRH agonist short regime, it was 10.5. GnRH antagonist regime, it was 10.5. And you can see that total gonadotrophin use was 5,540 for GnRH agonist long protocol, whereas GnRH agonist for short protocol needed 4,809. GnRH antagonist regime needed 4,740. You can see that GnRH antagonist regime, the total gonadotrophin dose is on the lower side. So cycle cancelled in the GnRH antagonist regime was about 6%. Number of oocytes retrieved 4.42 with agonist long regime, 2.7 with GnRH agonist with short regime. GnRH antagonist regime group, it was 330. Mature oocytes 3.59, 1.92, 3.30. So higher number of fertilization rates was 52.4, 48.6, 49.4% with GnRH antagonist. So that you can see that in slightly GnRH agonist long regime is preferred to antagonist in terms of duration of in terms of number of oocytes retrieved and mature oocytes and fertilization rate. Fertilization rate is comparable to 52.4 to 49.4%. 49.4% in GnRH antagonist regime. GnRH agonist long regime, it is 52.4%. So, coming to the meta-analysis, GnRH agonist protocol in poor responder didn't show much difference in the live birth rate. When you come to the live birth rate, there is no difference. So, I told you. So, what is the modeling of controlled ovarian stimulation on the base of ovarian reserve marker? Anti-Mullerian hormone. So, expected high response. What should be your dosage? GnRH antagonist with 150 internal unit of FSH. So, AMH value, where you get a normal response, it could be that you could use it to 225. Where you get a poor response, it could be that you could use 300. Expected absolute response, you can try with a modified natural cycle. So anti-Mullerian hormone, it is based on this anti-Mullerian hormone level 28.6%, 28.6 picomole per liter. You can use GnRH antagonist 150 international unit of FSH. 15.6, you can use 200 international unit of FSH. It is 2.2 GnRH antagonist with 300 unit of FSH. Then expected absent response, IVF has to be denied. So this is the dose of gonadotropins based on the anti-Mullerian hormone on picomole per liter. Where you get an expected high response in antagonist, it will be 150. Where you get a hyper response, where you get a low response, where you get a normal response, it could be 225 or 200. With agonist, it could be 225. With antagonist, it could be 200. And with expected poor response, with antagonist, it could be 300. GnRH antagonist, 300 international unit of FSH. So this is the comparison of gonadotropin dosage based on the anti-Mullerian hormone. So modified natural cycle, 136 patients were studied, 390 cycles were studied, no subgroup distinction was made, live birth rate per cycle didn't differ among any age group, less than 35, 36 to 39, and more than 30. Kedem et al. In 2014, live birth rate cycle was 0.9%. Linus et al. Live birth rate 7.5%, vice 3.1%. Now we come to the mild stimulation protocol, where you have a combination of clomiphene citrate and gonadotropin in a GnRH antagonist protocol. It is not superior to gonadotropin in an GnRH agonist protocol in terms of live birth rate. So comparison of CC plus gonadotropin in the antagonist protocol is not superior to gonadotropins in a GnRH agonist protocol. So the combination of clomiphene citrate and gonadotropin in agonist protocol in 250 poor responders reported a significantly lower clinical pregnancy rate with clomiphene citrate addition in compared to no clomiphene citrate, which was not associated with the number of oocytes retrieved. So you can see that when you combine clomiphene citrate and gonadotropin antagonist protocol, you are getting a lower pregnancy rate with clomiphene citrate addition, where you are not adding clomiphene citrate. Now, accumulation of oocytes, that you use various cycle and you pool the oocytes, is a new strategy for managing lower responder patients. So accumulation of oocytes from several ovarian stimulation cycles in currently possible using novel vitrification technologies. So this strategy would increase inseminated cohort, creating a similar situation to normal responders. So live birth rate was higher. Cumulative live birth rate patient was statistically higher in this group. Now physiology. Now here comes the DUO stimulation, where what was the new thing? It came to the conclusion that multiple waves of follicle development during the menstrual cycle provides a new model for understanding the human follicular development. Ovarian follicles are available for ovarian stimulation throughout the menstrual cycles. Independently of gonadotropin fluctuation, and the resulting oocytes are mature and competent. So what is the conclusion? Recruitable andral follicles are continuously present. Recruitable andral follicles are continuously present in the ovary during menstrual cycle. Multiple cohorts or veins of 2 to 5 millimeter follicles are recruited continuously during a menstrual cycle. What is a wave? A wave is a synchronous growth of follicle that have similar diameter. So what happens is that you have these waves recruited continuously. It's not that it is in the follicular phase alone. So waves or waves emerging in the luteal follicles are almost anovulatory. So there are 3 waves of follicle growth. The waves of follicle recruitment suggest that 2 or more waves of andral follicles emerge during the ovarian cycle. In women with 2 follicular waves, anovulatory waves emerge in the earlier luteal phase, followed by the ovulatory waves during the follicular phase. 3 waves, one is an ovulatory wave at the time of ovulation. Second ovulatory wave emerged during the mid to late luteal phase, and the ovulatory wave emerged in the early to mid follicular phase. It could be that a woman is having 2 follicular waves, or is that she could have 3 waves. The dominant follicle develops in a minority of andral follicle. So follicle cyclotreatment in a single dominant person is chosen from the recruited cohort or wave of for potential growth. So you will please look at the FSH threshold and window. You look at the spontaneous cycle, you look at the follicle wave. Conventional ovarian stimulation, you look at the follicle size. You can see it is growing. Then you can see the luteal start. You can stimulate it in the luteal phase also. The only thing is that during luteal phase, a longer FSH window permits multiple follicle growth. You can see that in the early follicle. Now this is the size of the follicle in millimeter. You can see the follicle is growing to that size. Now in the luteal phase also you get that. You can see in the normal cycle, you can see the follicular waves. You can correlate. It is more common in the early follicular phase. In the luteal phase also you get this. So FSH threshold and window in a spontaneous conventional ovarian stimulation and luteal start ovarian stimulation. During the luteal phase, a longer FSH window permit multiple follicle growth. The follicle waves could be recruited by a constantly high concentration of FSH. This new knowledge of ovarian function, in particular the theory of multicyclic development of follicle during the menstrual cycle, resulted in the new approaches to ovarian stimulation, that is the double ovarian stimulation, commonly known as the dose regime. The concept that continuous ovarian follicle growth and disarticulation of the stimulation embryo transfer led to the possibility of performing consecutive ovarian stimulation cycles and oocyte retrieval procedures in order to increase the number of oocytes available per patient in a given cycle. So double ovarian stimulation consists of 2 successive ovarian stimulations in the follicular and ensuing luteal phase with 2 oocyte retrieval at the end of both stimulations. So double stimulation regimes, 2 successive ovarian stimulation with the 2 oocyte retrieval at the end of both ovarian stimulations are performed less than 1 month. The first ovarian stimulation start during the follicular phase. So double randomly started ovarian stimulation, 2 successive ovarian stimulation with 2 oocyte retrieval at the end of ovarian stimulation are performed in approximately 25 days. So that in 25 days you got 2 crops of oocytes. The first ovarian stimulation can start randomly during the menstrual cycle during the luteal phase. Second can begin only after the first oocyte retrieval. If ovarian stimulation start during luteal phase, normally some days of gonadotropin therapy, menstruation may occur. So only thing we know that you cannot do a fresh transfer. You need a cryopreservation of transfer because it doesn't allow a fresh transfer. Cryopreservation of either the oocytes or embryos or preferably blastocysts is indispensable. So luteal phase stimulation was originally used to produce mature oocytes and embryo. Andral follicle in the luteal phase had a similar, this is what we should understand. Andral follicles in the luteal phase have got a similar development potential with potential pregnancy outcomes in a subsequent cryopreserved sample. So this is the Shanghai protocol. What do you do? you do a combination of clomiphene citrate 25 milligram starting on the day of cycle until the triggering of ovulation. So here you start clomiphene 25 milligram on day 3 of the cycle until the triggering of ovulation, and letrozole 2.5 milligram starting on day 3 for a total of 4 days, and human menopausal gonadotropin HMG 150 starting on day 6 until the triggering of ovulation. So what you are doing is clomiphene citrate the day of the cycle until the trigger of ovulation, letrozole again on the 3rd day for 4 days. Then you can see that you are giving a human menopausal gonadotropin on day 6 until the triggering of ovulation. For luteal phase, what you do is letrozole 2.5 milligram per day, HMG both starting the day of the first oocyte retrieval until the 2nd triggering day of ovulation. It's different because in the first phase you are using clomiphene citrate initially, letrozole from the day of cycle till triggering of ovulation, letrozole from day 3 to day 3 for a period of 4 days, and human gonadotropin you are starting on day 6. But in the case of a luteal phase, you are taking letrozole 2.5 and HMG 225, both starting from the day of the first oocyte retrieval. So medroxyprostanostate was also administered in the end of both. For both stimulation, ovulation was triggered with piperacillin 0.1 ml, and follicle maturation was finally achieved. Now here you can see clomiphene citrate continued till the GnRH agonist given. Letrozole is given for 4 days, ibuprofen given, and then you are having the HMG started from the 6th day. Now in the luteal phase, what you see is that you are having HMG started immediately, and again you can see you are giving letrozole continuously along with HMG. So in the luteal phase, you are adding letrozole. In the follicular phase, you are adding clomiphene, letrozole plus HMG on the 6th day. Here we are adding it on the same day. So it provides more opportunities for retrieving oocytes in the poor responders. Now, confirm that both follicular phase and consecutive luteal phase stimulation. This is our new concept. We all stimulate in the follicular phase, but we are able to stimulate the ovary both in the follicular phase and in the consecutive luteal phase. No statistically significant differences were found in the number of treated oocytes, M2 oocyte, blastocysts between the two stimulants. Don't think that there is any difference in the number of treated oocytes, M2 oocyte, blastocysts, or euploidy blastocysts in the late luteal phase also. So dual stim concept with 2 consecutive stimulation within this thing. You can see 3-well cycle. Now you can see the total of 30 women, 38 women recruited. 2 of the following criteria: age over 40 years with the history of ovarian surgery, previous treatment with a conventional protocol that yielded less than 3 sites, 3 oocytes, androgen follicle count less than 5 on the menstrual cycle, basal serum concentration between 10 and 90 international units per liter. So double stim stimulation during the follicular and luteal phase of poor responders is the Shanghai protocol. So now, as I told, we have already discussed about the dose of gonadotropins. So coming to the postulant group. So in postulant group 1, what you can do, increase the dose 50 to 75 if no variance, 70 to 150 unit if FSH variance is there. Postulant group 8, more than 35, recommend FSH dose of 300 national unit per day. So group 1, I already told, age less than 35, you have to do 75 to 150 unit of FSH. Then maximum is 300. Now considering you can add LH also in the protocol, and postulant group 2 and LH 150 national unit daily from the stimulation from day 1 in both agonist and antagonist regime. This is the postulant group 2. So consider antagonist regime, GnRH trigger and electric embryo freezing in case of androgen follicle count is more than 60 or anti-Mullerian hormone is more than 3.6 nanogram per ml. Now, you have to consider pre-implantation genetic test for aneuploidy in the postulant group 2. So postulant management of prognosis patient group 3 where the age is less than 35, but their ovarian response is poor. So poor ovarian reservoirs, long GnRH agonist protocol, GnRH antagonist, estradiol or contestive, stimulation with 300 units per day, and FSH or androgens may be useful. Group 4, poor ovarian response. You can see that antagonists could be added, stimulation with 300 international unit, FSH, add LH2 stimulation, that could be useful. So best practice in the group, progesterone group 3 and 4, adjuvant treatment, yes, androgens, growth hormone, coenzyme Q10 can be used, long protocol, estrogen or contraceptive, antagonist therapy can be used. Adjuvant treatment, more than 35 years, androgen or growth hormone, long protocol, estradiol or oral contraceptive, aggrionist, duostin. So you can see that in more than 35 years and less than 35 years, if it is a lady with a low ovarian reserve, as already highlighted, you can use a long protocol, you can use a pre-antagonist duostin regime, you can use androgens or growth hormones. So best practice in group 3 and 4, 300 international unit of recombinant FSH, you can use HMG or recombinant FSH. Progesterone group 4, you can use HMG or recombinant FSH. So long protocol, HCG trigger, antagonist protocol, GnRH agonist or HCG trigger, duostin, always GnRH trigger. So consider adjuvant treatment where you get a low follicle index that could be used. Oocyte or embryo accumulation, antagonist protocol, duostin, long protocol, new stimulation could be used. So cumulative live birth, it could be that the low prognosis patients were based on the progesterone criteria. So what is the new in the management of poor response in IVF? So asynchronous, you can see development progestin, oral contraceptives, GnRH antagonists, increase FSH daily, and you can add LH 75 to 150 units per day. In group 3, you can use the double stimulation, not in the group 1 and 2. Duostin protocol used only for group 3 and 4. You can add LH, you can use the dose of gonadotropin, double stimulation protocol could be used. So what does it do? It improves the recruitment, development of the follicle, multiple follicular waves during one menstrual cycle has offered new possibilities for ovarian stimulation. So in group 3 and 4, you can try this duostin protocol. So in group 1, promote and synchronize follicle wave development before control ovarian stimulation. FSH dose does not reach the minimum threshold of adequate follicle recruitment. To improve the FSH receptor expression in granulosa cell, to improve the sensitivity of FSH dose and recruitability, there your androgens and growth hormone will come to play. So what are the adjuvants? You can use androgens, you can use LH, could be useful. So LH supplementation may confer benefit in poor ovarian response. This is really for young patients. Older poor responder patient, recombinant supplementation may not provide a benefit. So this is very important. Suppose you are planning to add recombinant LH. This is in a patient who is having a poor responder. You use a young group, not in an older poor responder. LH may not be of much benefit. So relationship between androgen and folliculogenesis. Within 2 to 5 millimeter follicular range, significant positive relations between the follicle number per ovary and androgens. Inadequate level of endogenous androgens are decreased with ovarian sensitivity to FSH and low pregnancy rate. So what do you need? You should need an inadequate level of endogenous androgens. Endogenous androgens are very, very important. Adequate androgen level at a small growing follicle stages. Androgens act synergistically with follicle stimulating hormone, enhance sensitivity of the granulosa cells to FSH, and therefore promote follicle growth and development. Absence of adequate androgen level in the early maturation results in an increased follicle degeneration and apoptosis. So what do you understand? Adequate androgen level at the early follicle is very much important to prevent follicle degeneration and apoptosis. So testosterone, how do you do? What is the rationale for giving testosterone in poor responders? It stimulates early follicle growth and increases the number of pre-andral and andral follicle. So it augments the FSH receptor expression in the granulosa cells, and potentially lead to enhanced responsiveness of the ovaries to FSH. So testosterone gel treatment for 3 to 4 weeks. Testosterone gel treatment you can give for 3 to 4 weeks increases the antral follicle count and ovarian stomach blood flow, thereby potentially improving the ovarian response, control ovarian stimulation, and outcome in poor responders. Also, what you have to do, you have to give testosterone gel for 3 to 4 weeks, that is nearly for 1 month. What does DHEA help is helpful? DHEA is useful to improve the follicle microenvironment oxygen levels in the follicular fluid that is crucial to the development of oocytes and embryo quality. So there is no absence of significant side effects. So I'm trying. No, that's not an argument. But there is a but we have to have a very clear-cut consensus that there is no significant difference in the clinical pregnancy rate and miscarriage between women pre-treated with DHEA compared to those without DHEA treatment. So there is insufficient data to support the beneficial role of DHEA as an adjuvant to controlled ovarian stimulation. So again, I tell you, based on the limited available evidence from a total of approximately 200 IVF cycles, there is insufficient data to support the beneficial role of DHEA as an adjuvant to control ovarian stimulation in IVF cycle. So DHEA, 48 women diagnosed with ovarian response to DHEA supplementation. So who didn't receive supplementation? In conclusion, no benefit was found in the administration of DHEA in a woman with a previous poor response to ovarian stimulation. Patients should be counseled adequately about the uncertain effectiveness and the potential side effect of the treatment. There is insufficient data to have a beneficial role of recombinant LH, SCG, DHA, or letters administration in the probability of pregnancy in poor responders undergoing ovarian stimulation. So ovarian features after 2 weeks, 4 weeks, and 6 weeks after transdermal testosterone gel treatment. You can see that after 3 weeks of testosterone gel treatment, significantly increase in antral follicle count and a significant decrease in the mean follicular diameter has been found. So testosterone pre-treatment for 3 to 4 weeks increases AFC and ovarian stroma. So number of oocytes retrieved, number of embryos, pregnancy rate, implantation limit using transdermal androgen before control ovarian stimulation were found higher than those in the control group. So use of androgel before stimulating ovarian can improve the responsiveness of poor responders in undergoing IVF. So effective transdermal testosterone gel treatment on controlled ovarian stimulation was recommenced after testosterone gel administration. So transdermal testosterone is giving conclusion, increases the live birth rate and reduces the dose of FSH. Then what about growth hormones? Administration of growth hormones, it could be from a dose of 0.5 international unit per day to 12 international unit per day. Growth hormone protocol should be in a small dose. On day, you can give it in various things. On day 2 to 3 during the preceding menstrual cycle, 1.5 international unit per day for 6 weeks prior to trigger with SCG. Growth hormone could increase the implantation rate. So growth hormone is administered in the pituitary down regulation phase. Growth hormone in a dose of 12 international unit per day till the day of SCG. Low dose of growth hormone, 0.5 international unit per day until the SCG dose in the luteal phase for pituitary down regulation can be used. So retrospective case control study used growth hormone supplementation in the middle luteal phase in a dose of 3.3 milligram, reported no improvement in this. So one study performed in China, supplementation of growth hormone in a dose of 4.5 international unit per day at the start of gonadotropin could give an increased number of oocytes collected, metaphase 2 and fertilized oocyte. Biochemical pregnancy rate, clinical pregnancy rate, implantation are higher in the growth hormone than in the control. So growth hormone could be added in the 6th day in a dose of 2.5 milligram per day until the day of SCG. That means 2.5 milligram per day means 7.5 international unit per day. So mean number of oocytes collected, metaphase 2, fertilized oocyte, quality oocytes, intermediate thickness are increased in this group. So growth hormone supplementation, growth hormone modulate the activity of FSH on granulosa cell through the adjustment of a local synthesis of insulin-like growth factor that magnifies gonadotropin activity. Before recommending growth hormone supplementation idea, further studies are needed to characterize its role. So you can see that more studies are warranted before the administration of growth hormone in expected poor ovarian response, optimal dose and duration of administration is still missing. So efficacy of luteal phase Eastern administration and early follicle gonadotropin releasing antagonist protocol that could be used. You can use estrogen priming in the luteal phase, and then you can add GnRH agonist, especially in patients who are having high LH level. So in the last couple of years, emerging treatments are being investigated in infertile population setting. In vitro activation of follicles and drug-free in vitro activation has attracted much interest. Drug-free in vitro activation preliminary results are encouraging. Increased annual follicle count, increased metaphase 2, and 6 patients with clinical pregnancy. So recommendations for poor responder management. GnRH antagonists and agonists are equally recommended. Clomiphene citrate in combination with gonadotropins and gonadotropin simulations are equal. The addition of letrozole to gonadotropin simulation protocol not recommended. A gonadotropin 300 international unit is not recommended for predicted poor response. The use of modified natural cycle is not recommended over conventional stimulation for predicted poor responders. Use of adjuvant growth hormone before and during ovarian stimulation is not recommended. Use of sildenafil, DHEA, aspirin before and during ovarian stimulation is not recommended. Testosterone before ovarian stimulation is not recommended for poor responders. Double stimulation should be used in the context of clinical research. Late luteal phase gonadotropin is probably not recommended. Early luteal phase start gonadotropin is probably not recommended. So this is the summary. Prognosis in poor ovarian response should be evaluated more precisely according to different combinations in the Bologna and Crossdon group. GnRH agonist and GnRH antagonist protocols are effectively effective. The starting dose should be 300 international units per day to a maximum of 450 international units per day. Supplementation of recombinant in hyper-responders. Accumulation of oocytes to embryo is a new therapeutic approch. Transdermal testosterone treatment seems to increase pregnancy rate and live birth rate in poor responders. There is insufficient data to support the beneficial role of DHA or external administration in the probability of pregnancy in poor responders undergoing ovarian stimulation for hyperstimulation. So thank you. Hello. Hello.
Sir, am I audible now, sir?
Yeah, I am audible. You are audible.
Yeah, yes, sir. Thank you, sir. Thank you very much for your wonderful presentation, sir. And with your presentation, we can come to know that FSH not only triggers follicles in the follicular phase, but also in the luteal phase, which is something new to us, sir. And yes, sir, treating POR is again a challenge in ART. And thank you, sir. Thank you for sharing this Poseidon and Bologna criteria, sir. And sir, let me wait for 1 or 2 minutes for the participants to post their queries so that I can read it for you, sir. Sir, the risk of aneuploidy is same for all those 4 groups of Poseidon criteria, or whether it is different, sir?
That is more in group 3 and 4.
Okay, sir.
Yeah.
Sir, whether this amino acids supplement can improve this ovarian reserve, because in normal responders who have enough ovarian reserve, whether we can give them this amino acids like leucine, arginine can be beneficial for them, sir?
It can be beneficial, but only suppose they have got some gene problem of responsiveness, it is not good. As I already highlighted, it could be that there could be a genetic problem in there. That is where you expect a normal response, but you are not getting it could be a polymorphism of the gene. So in those cases, it will not help. Otherwise, it can help.
Okay, sir. Sir, you are discussing about this accumulation of oocytes, sir. Whether the protocol is same for that condition also, or whether there is any different protocol for accumulation of these oocytes, sir?
You can use mild stimulation protocol for that. Mild stimulation protocol, you can use letrozole plus gonadotropins and antagonists, and you can pool the oocytes.
Okay. Questions? Sir, I don't find any other questions in the chat box, sir. So if you allow us, then we can wind up the webinar for today, sir.
So thank you very much for the Shield Healthcare for giving me this opportunity. So this was a challenging area, and thank you for your initiatives in involving this lecture. Thank you very much.
Sir, there is one question. The question is like, if the patient is age 35 and if letrozole is taken for 1 month by mistake, will there be a ovarian hyperstimulation syndrome? If she doesn't conceive, how to go about it?
And now that depends. Now we have to study the patient. You have to look at the reserve of the patient. You have to look for the annual follicle count, and as I already told, you have to have the ovarian reserve test study. Then only we will be able to comment on that.
Okay, sir. So thank you, sir. Thank you for being with us today, and thank you for sharing your valuable time with us, sir.
Yeah.
And thank you, sir. Many thanks from the family of Shield Healthcare, sir.
Thank you. Thank you. Bye.
Thank you very much, sir.